2, 3. Hello, Dr. Calra. Thank you for coming. It was a really wonderful play.
It's on now. I could hear it.
Okay. I shan't say anything too bad then. No, she's in Portugal. She's learning Portuguese. She's trying to escape the insanity. She's coming back May 2nd. That would be very tough. Yeah. Okay. So now, okay, great. Great. Sure. Go ahead.
Thank you, Portugal, for being my co-organizer.
There you go.
Thank you all for not needing this, but it sounds better with it, I think. It's a great pleasure to introduce Dr. Bill Winter. He received his MD degree from Loyola University in Chicago, and he then did a pediatric residency at the University of Kentucky. And after that, he did a pediatric endocrinology fellowship, so subspecializing further here at the University of Florida, which was great because he stayed for the rest of his career, and we were the great beneficiaries. So he's been a member of the Department of Pathology, which has a much longer name that I probably could have said in the time it took to tell you that, but
you get paid more if you say
we'll leave it simple as pathology. But during his 30 or almost 40 years, I think, in the department, he has published over 200 peer-reviewed articles, books, chapters. He's held multiple NIH grants with continuous funding for over 20 years. And his teaching has, in some ways, even overshadowed his other spectacular accomplishments, including a Lifetime Achievement Award, Basic Science Teacher of the Year, and these are voted on by the medical students. So, you know, how many...
What do they know? What do they know?
Well,
they made mistakes.
They know how many other faculty we have, and they chose Bill. So, exemplary Teacher of the Year 3 times, and a Pathology Teaching Award called the Golden Apple twice. So this is, Bill's a great teacher and wonderful colleague for me to have had in pathology for 30 plus years. So welcome, Bill.
Well, thanks. Thanks very much, Ken. Can you hear me? Okay. Pay attention. There's a test at the end. About 4 hours will be done. You ready? Okay. Well, thank you very much for the invitation to speak. It's good to see old friends here. Old only because I've known them for a long time. None of us are old. We're young. So Ken asked me to talk about the metabolic syndrome. And, let's see, that's not what I wanted to talk about. There we go. So the way I've set up my slides are I usually start with a question and then I answer it. And would you prefer that we hold questions till the end? You want questions at the end? Okay, but I might ask you a question. So the metabolic syndrome is extremely common, and I'll talk about how common it is. Who has heard of the metabolic syndrome before? Okay, quite a few of you. Okay. Who knows what the metabolic syndrome is? Okay, you're going to be on slide 5 and you're going to be on slide 7. Thank you. So in terms of frequency, the metabolic syndrome is really probably the most common endocrine disorder that affects adults. And it's very common in children as well. We'll talk about, again, frequency as we define it. But there are 2 other disorders that are common that fall under the rubric of endocrine disorder, and that's type 2 diabetes. And that's extremely common. As we get older, it's more common. And it's actually a part of the metabolic syndrome. The other endocrine disorder that is very common is actually thyroid disease. And I'm not going to talk about thyroid disease. So if Ken asks me to come back and talk again, we'll talk about that butterfly gland in your neck. So let's define some terms. When I try to understand things, I have to define terms. I have to look up things. I was talking to a friend recently about trying to read instructions of how to do things on your computer or the internet. And I read the instructions and I don't even know what the terms mean. You know, the such and such a button and do this and do that. Endocrine is a branch of physiology and medicine concerned with endocrine glands and hormones. And then right away, we have to know not only what endocrine means, but what glands and hormones mean. So let's talk about glands. When I was a kid, I thought hormone was a dirty word, and I ended up an endocrinologist. So what is a gland? What is a gland? Does it contract? In some ways it does. Does it contract like your heart? It secretes. The characteristic of a gland is that, and you must have seen my slides ahead of time. Thank you, sir. It's a organ that produces secretions. And the general types of glands that exist are two, exocrine and endocrine. So for example, a exocrine gland, the characteristic of this type of gland is it secretes secretions into a duct. An example of that would be the parotid gland. So a parotid gland is up here in our upper cheek, and it has a duct, and that duct supplies salivary fluid into the mouth. And what is the disease that maybe some of us have seen or had when we were young, when your parotid glands got swollen and you'd be sick? Mumps, okay. Now, other exocrine glands are worthwhile thinking about as well, just as an example, sweat glands. A friend of mine, I was driving to the airport today, and that's why I couldn't join you for lunch. But my friend Steve and I, we were at the Cade Museum. Who's ever been to the Cade Museum? It's really quite interesting. I learned that women have more sweat glands than men, but men can sweat more than women. So here's an exocrine gland. We've got millions of those on our skin. It produces sweat, and out of a duct it comes. The pancreas is also an exocrine gland. The pancreas produces digestive juice. The pancreas empties, pardon me, empties into our duodenum. What's upstream of the duodenum? Dr. Cholera can't answer. I know she's got a medical background. That big sac that fills up the stomach. This is part of our intestine. The pancreas produces digestive juices, and as an exocrine gland, it empties those juices into the duodenum. And it produces a lot of bicarb as well as digestive juices. Does anyone know why the pancreas produces bicarb, which is alkaline? It neutralizes the stomach acid. It's natural Tums. Okay. Now, as I go into this, I also want to let you know that there are a variety of different ways that cells can communicate with one another, and one of those is through the endocrine system and hormones. When you have the signal cell that's producing some type of chemical signal, and the target cell, when they're quite distant, and the signal has to be transmitted through the circulation, this is an endocrine system. So the signal cell, pardon me, do you have any water? A little bit of water would be fine. So the distant cell, the target cell on the left, the signal cell on the left and the target cell on the right are quite distant from one another. And most of the classic endocrine systems that concern us, whether it's regulating our calcium or regulating our blood glucose, our energy status, they work like this. But there are also other systems that are paracrine systems where two cells side by side communicate with one another. We're going to talk a lot about insulin. Does anyone know where insulin is produced? It's produced in the pancreas. Only about 1 to 2 grams of our total body weight, thanks. That's good. Thank you very much. Only about 1 to 2 grams of our whole body is actually islets, and the islets are key to controlling blood glucose. Within the islets are the cells that produce insulin. They're called the beta cells. There are other cells within the islet that produce glucagon, where insulin lowers glucose, glucagon raises it. And the cells are very close together, and they actually influence one another in a paracrine. And we're not going to cover this in detail. That would be the nth lecture down the road. Another type of communication system is autocrine, and that's where a cell produces a signal and responds to it. But we're going to be focusing really on endocrine types of non-exocrine communication. So an endocrine gland, well, endocrine glands produce secretions, but they secrete them into their surroundings. There's no duct. So it's by diffusion that this signal will enter into the space around a cell, which is liquid. Even though we're on dry land, we actually carry the sea within us, if you think about it. If we evolved in the ancient oceans and animals moved, like, does anybody ever read Frank and Ernest in the comic strips? You read comic strips? Frank and Ernest, they've always, every year or so, they've got a cartoon about where Frank and Ernest came from. You know, they came from fish and maybe not insects. And the idea, though, is that life originated in the ancient seas, and we carried the seas within us. So it's not necessarily salt water, but the fluid that our cells are bathed in, that's interstitial fluid. So the endocrine glands secrete their products into the fluid around those, and then those products diffuse into the circulation, and then they diffuse into the target. Endocrine glands produce a type of messenger that we refer to as a hormone. And biologically, some hormones are derived from fats, some hormones are derived from proteins, some hormones are as simple as a single amino acid, which is the most basic building block of proteins. So these are chemical messengers between cells. They usually regulate some aspect of metabolism. They stimulate or suppress a whole variety of processes. And one of the reasons why I went into endocrine when I was early in my career is that there was a lot of biochemistry in it, which I thought was very interesting. And in many, if not most endocrine disorders, there is a treatment for them. You find a deficiency, you replace it. If there's an excess, there are ways to suppress it. The predominant example of an endocrine gland that we're going to talk about is the beta cell, which produces insulin. The pancreatic beta cells, they're the major cell within the islets. Again, these are collections of cells, islets, within the exocrine pancreas, the digestive pancreas. So the pancreas does two things. Most of it is digestion, but it has a small amount of it that is endocrine. And within the islets, the islet beta cells are the sole source of insulin. And insulin is one of the most important hormones that we have, because we'll see that it lowers blood glucose. If you don't have enough insulin, what would happen to your blood sugar? If insulin's normal action is to lower blood sugar, it goes up. Yeah. So too much blood sugar is bad. And I have a slide coming up that chronic elevation in blood glucose causes what condition? Diabetes. On the other hand, is too much insulin bad? You betcha. If you have too much insulin, your blood glucose will go down, and your brain, at least in the short run, always needs glucose. So the glucose level in the blood is highly regulated. Too little is bad, too much is bad. And insulin acts on the liver, muscle, and adipose tissue. And the net effect is that these tissues will be stimulated to either metabolize or increase their uptake of glucose, and the glucose in our plasma will fall. A couple of other hormones besides insulin. I'll spend an hour on each of these examples at a later time. So what is necessary for a cell to respond to a hormone? If you play baseball and you're the pitcher, what does the catcher want to have other than just a mask over his or her face and a plate? They need a mitt. That's right. They need something to receive the signal. So there has to be a receptor. One of the popular ways of thinking about hormones and receptors is it's like a key and a lock. A hormone is the key, and the lock is creating the action of the hormone at the target tissue. So in the case of insulin, there are on cells of the body insulin receptors that when insulin binds to that receptor, second messengers become generated. So it's a little bit like a Rube Goldberg type of apparatus. And the messengers that are created for insulin are extremely complex. And for both your sanity and mine, I'm not going over that little tiny diagram over on the right. But receptor interacts with the hormone, second messengers are activated, and that would lead to the hormone action. And in the case of insulin, that would lower your glucose. And we don't have any backup. We don't have any other hormones in the body that will lower our blood glucose. But it's interesting. Any guesses about how many hormones we have that will raise our blood glucose? Any guesses? 4. That's great. We actually have 4 hormones that raise our blood glucose. Growth hormone and cortisol do it slowly. Epinephrine and glucagon do it rapidly. So in essence, evolutionarily, we're really evolved to protect ourselves more from hypoglycemia than hyperglycemia. Hyperglycemia will kill us in the long run, but hypoglycemia can kill you immediately in the short run. So the evolution is that we have many, many more ways of raising our blood glucose than lowering it. But of all those hormones, insulin is the most important. There are other chemical messengers in the body that are worth thinking about when we're thinking about communication between cells. One of those types of chemical messenger is a cytokine. In the immune system, cells communicate like other systems within the body, and cytokine is a generic term for chemical messengers in the immune system where at least one of the cells is a cell of the immune system. So lymphocytes are extremely important. If you knock out the lymphocytes, you get terrible immune deficiencies, you get terrible cancers. What was the virus that was discovered back in the 80s that actually infects a subset of T lymphocytes? T because they come from the thymus gland. HIV. The HIV is such a devastating disease because it destroys the cells that are the most important cells initially in recognizing the foreign pathogen and responding to them. In this example, a T lymphocyte that's a type of helper cell, that's what the H is for, is helping a B cell through a cytokine called interleukin-2. Interleukin, between leukin white, so between white cells. And then that B cell would become activated and become a plasma cell and produce over on the right antibody. In the nervous system, neurotransmitters are chemical messengers between cells. So we have dendritic cells that we have a cell here that has this long projection, and it makes physical contact with the cell that it's going to stimulate in something called a synapse. Oh, I didn't do that very well. That's better. And the synapse is where the chemical communication occurs. In a sense, would this be endocrine, paracrine, or autocrine? I told you there was a test. That would be paracrine. Two cells next to one another communicating with a messenger. So even though I trained as an endocrinologist, I think a lot of the concepts of endocrine apply to other systems that are fascinating. And even though I wasn't trained as an immunologist, I taught immunology to the medical students for a long, long time. So to understand the metabolic syndrome, which we're going to get to, did you say I had to end by 2:30, Ken? Good. Yeah, I think we're okay on time, or 2:15. To understand the metabolic syndrome, we need to understand how insulin is regulated and its actions. So I'm going to take that diagram that I showed you and make it a little bit more complex. It is a negative feedback system, and it will achieve steady state. So if you perturb the negative feedback, something will happen. If you added glucose, there'll be more insulin. The glucose level will come down. You're back to steady state. So if you think about glucose, we really have two sources. If you've had lunch in the last hour or 90 minutes or so, glucose is being absorbed by your intestine and it's entering your body. When you fast and there's no glucose coming from your intestine, you have glucose coming from your liver. If you perturb the system and the glucose level goes up, let's see, I must have pushed the wrong button here. Great. The beta cell perceives that. So the beta cell is not only the cell that produces insulin, it monitors your blood glucose. It's a standalone system. It's amazing. And if glucose goes up in your bloodstream, the beta cell will produce more insulin, and there will be increased metabolism and uptake of glucose, and the glucose will come down, and you'll have a negative feedback system. But it won't go down to zero. It'll just come back to baseline. So this is a negative feedback system. You have to have a beta cell that can sense glucose, that can produce insulin, and you need the receptors to work and post-secondary messengers to work. So the system requires the hormone, but it also requires the targets to respond normally as they should. So at steady state, the rate of production equals the rate of clearance. It's kind of like if you look at a stream and you look at the height of the stream, you're not really sure, unless you look at how fast the water is running, what the rate of production and the rate of clearance is. What happened in Frankfort, Kentucky in the last few days? The water went up. I heard that the usual water was like 12 feet, and because of the rains, it had gone up to 48 feet. I don't know if it's even worse since then. But they added more water. They added more glucose. If that was the body in a healthy individual and you added more glucose, you would have cleared more glucose. So glucose ingestion. So the intestine, okay, whether you're ho-ho, ding-dong, little Debbie snack cake, whatever you've had for lunch, probably, hopefully something real healthy. The glucose went up, the insulin went up, the glucose was cleared, and you came back to negative steady state. So again, if you like to read things, more glucose enters the system. It's monitored by the beta cell, insulin was secreted, and then more glucose was removed and you're back to steady state. The metabolic syndrome relates to aberrations of this system. So as more glucose enters the system, more insulin is secreted to increase glucose clearance, and you have an NL. That's not National League, that's normal glucose. So what happens if the insulin receptor / post-receptor signaling machinery is resistant to the normal effects of insulin? And let's assume the beta cell is healthy. What will happen then? The beta cell will produce more insulin, and you would have a state of hyperinsulinism. So beta cell secretion increases if you become insulin resistant. And here, a concept that's helpful is that insulin action on the right is the product of two factors: tissue sensitivity and the insulin concentration itself. So if you have a normal response to a decrease in insulin sensitivity, the pancreas will pump out more insulin, and that will maintain a normal glucose. On the other hand, what happens if sensitivity declines and the insulin concentration doesn't increase adequately to compensate? Okay, so we're back to that equation. Sensitivity times insulin concentration, those brackets mean concentration. When you take chemistry, they'll talk about things in brackets, that means concentration. What if your insulin sensitivity went way down and your insulin concentration went up, but it didn't go up to match that insulin sensitivity? You've got a decrease in insulin action and a mild increase in glucose. So you really have hyperinsulinism compared to normal, but you don't have enough insulin action. Well, what if your insulin didn't go up at all? It just had normal levels and your insulin sensitivity has gone down a lot. Well, you're going to even have more hyperglycemia, 2 arrows up. And now, if you have not only insulin resistance, but a defect in the beta cell, it's even going to be worse. You're going to have more hyperglycemia. And we've already answered this question. What is the diagnosis if the glucose concentration is chronically elevated? You have diabetes. You have diabetes, sure. So what can cause diabetes? Well, if we go back to this equation, anything that causes a chronic decline in insulin action will cause diabetes. And in the less common form of diabetes, which is type 1, the beta cells are actually destroyed by an autoimmune process, an inflammatory process where the immune system gets very confused between self and non-self and begins to attack those cells and destroy them. So in type 1 diabetes, which is predominantly a diagnosis of youth, but it can occur at any age, the insulin will be low because you can't make it. On the other hand, if you look at type 2 diabetes, the more common form of diabetes, it becomes much more common as we age, especially over age 40. There's a combination of 2 factors. Most commonly, the problem is a problem with insulin sensitivity, and you have not enough insulin to compensate. Now, there may be some increase in overall insulin, but it can't overcome this severe insulin resistance. So type 2 diabetes is a really predominantly, most commonly, a disease of insulin sensitivity. And again, this is just to say absolute insulin concentration may be high, but inadequate to control the glucose. You're going to get your degree at the end of the lecture. So what's the most important cause of insulin resistance? Well, it's obesity. Obesity can cause the metabolic syndrome. And there's a lot of factual data about how obesity causes insulin resistance. And for the sake of time and sanity, we're just going to accept that it does. Now, is there any particular type of adipose distribution that's more likely to cause insulin resistance? If you have somebody who is overweight or obese, what are 2 of the most common fruit that we think of, excluding a banana? A banana. An apple and a pear, right. So if obesity is centripetal, like an apple, obesity, which is intestinal, around the intestines, as well as on the surface, this type of distribution of body fat is more associated with insulin resistance than pear-shaped. So here we have our little fellow here that I just drew up on the left, and he's got centripetal obesity. Well, if you become insulin resistant, your total insulin hopefully will go up, and you'll never get hyperglycemic, but that's not true for many people. You make more insulin, but you don't still have enough. So there are 2 things that are happening in the metabolic syndrome. Number 1, you are making more insulin than usual, and that has adverse consequences of itself. But yet, you don't have enough insulin action. So we want to talk about the consequences of an elevated insulin concentration, yet inadequate insulin action due to insulin resistance. So we have the metabolic syndrome as that consequence. And at least according to I think this is the definition from the American Heart Association, The metabolic syndrome is a group of reproducible, recognizable characteristics that relate central obesity and insulin resistance to increased cardiovascular risk, CVD, cardiovascular disease, and other problems. So the metabolic syndrome is just not type 2 diabetes. There are other factors. Now, there are a variety of other terms that have been used for the metabolic syndrome, and some of them are farcical, and I guess some of them are very serious. It was originally called the insulin resistance syndrome because that's the primary pathophysiology of it. It was called Syndrome X. I don't think this has anything to do with Elon. Diabesity. How would anybody come up with the term diabesity? A combination of diabetes and obesity. Morbesity. And then the cardiometabolic syndrome. Any guesses what type of physician would call this the cardiometabolic syndrome? Cardiologists, right, cardiologists. They're smart. They'll get in on it. And if you look at what is the most common cause of death in people that have the metabolic syndrome, it's cardiovascular disease, although there are many, many other complications from it. In terms of the federal government, which actually we all benefit from, they took all the terms, they put them in a whirring blender, and they came up with this term. So if you're seen for metabolic syndrome, insulin resistance, or type 2 diabetes, your doctor may be using these codes. Dysmetabolic syndrome X, you got them all here. Does anyone know what ICD-9 stands for? And it's written in very small letters down there. It's the International Classification of Disease. So when you see your physician and she or he are billing, they'll use these as disease diagnostic codes, and there's a number of different numbers. There's hundreds, if not thousands, of different numbers. Well, I've talked about the metabolic syndrome and diabetes, but it's more than that. Does anyone remember this young lady's name? She's actually not Wendy. She's Carla Peller. She passed away in 1987, but she was in the Burger King. No, Wendy's commercials, not Burger King. Wendy's commercials. Burger King's got the king. Okay. So the metabolic syndrome is more than just diabetes itself. In trying to respond to the insulin resistance, more insulin is produced by the body. There's data to show that having higher insulin levels actually put you at higher risk for atherosclerosis. That's where you have a fatty infiltration to your blood vessels. They can become occluded. They can cause ischemia. They can cause heart attack. They can cause stroke. And the relationship between the high insulin and atherosclerosis is certainly statistical, but it's somewhat controversial. But there's no doubt that people that are insulin resistant also are hypertensive. So now we're beginning to layer on the layers like on an onion. So if you have the metabolic syndrome, you're at very high risk to have hypertension, high blood pressure. Your blood actually is more likely to clot. And there's a factor that's involved in blood clotting that if this particular factor is high, your blood is more likely to clot. You're more likely to have a blood clot in a vessel. What's the medical term for a blood clot in a vessel? And we use fancy terms in medicine so we can charge more, right? I don't think so. Thrombus. Thrombosis is when you have a blood clot in a vessel. Hyperuricemia. Well, uric acid is a waste product. We pee it out. However, if you have a chronic elevation in uric acid and you have the right genetic susceptibility, what would it mean if you got a big, swollen, red, great toe that's extremely painful? Gout. So we've got now atherosclerosis, hypertension, predisposition to have blood clotting. We have now gout. Hyperandrogenism. Well, a certain amount of androgens are good, certainly both in men and women. But if you have too many androgens, women will experience increased body hair, And during their reproductive years, they can have fewer menses, no menses, or become infertile. So now this metabolic syndrome is affecting us in all kinds of different ways. So those factors, atherogenesis, hypertension, a propensity to blood clot, high uric acid, high androgens, are all atherogenic. We know that at least if you compare women during their reproductive years to men, if anybody's going to get heart disease, it's much more likely to be men than women. As women age, though, ultimately they will be at risk for atherosclerosis as well, but you usually outlive us by many, many years. Okay. So here we have that little man that I showed you before with lots of things happening in this cartoon. He has arteriosclerotic cardiovascular disease. He has hypertension. He may have had a stroke, high blood uric acid level relating to gout. Not only can the blood vessels in the brain and the heart be affected by atherosclerosis, the peripheral blood vessels can be affected, and that can predispose to gangrene, especially with injury. One other thing that I haven't shown up here, talked about yet, is this particular photograph. What part of the body is that? Yeah, that's the armpit, okay? And what you see is increased pigmentation there, and that's called acanthosis nigricans. So this metabolic syndrome has many different manifestations, and these are all believed to relate to the attempt of the body to compensate for decreased action. So if you look at people that have the metabolic syndrome, they have more risk of having gout, hypertension, atherosclerosis. Now, in the metabolic syndrome, even though the beta cells trying to compensate by producing more insulin, there can be so much insulin resistance that overall insulin action falls. And when insulin action falls, you don't have a normal glucose, which we could say generically dysglycemia. But when it's high, we have hyperglycemia, and then we have type 2 diabetes. So decreased insulin action and hyperglycemia then produce a pro-inflammatory state. And now we've got another factor that's adding to this metabolic mix. If you don't have enough insulin action, you can have abnormal blood lipids. The major abnormalities that occur are high triglyceride levels, low HDL levels, and dense LDL. If you look at the reports or your doctor talks to you about your lipid profile, usually it's how much your LDL cholesterol is. If you do more sophisticated testing, you can measure how dense the LDL is. And if the LDL is dense, it's more atherogenic. The low HDL, is that good or bad? You want to have a lot or a little? You'd like to have as much as you can. In fact, if you look at women, they usually have higher HDLs than men. Triglycerides are not as strong a risk factor for heart disease as are the LDL cholesterol, but if the triglycerides are extremely high, you can get inflammation of the pancreas called pancreatitis. Non-alcoholic fatty liver, or what's now known as metabolic dysfunction-associated steatotic liver disease. Man, you pay a lot for all those words, don't you? Liver metabolism is altered. When you have more fat in your liver, you produce a pro-inflammatory state. And I have a slide coming up very shortly to talk to you about liver disease in the metabolic syndrome. And the metabolic syndrome is actually, with liver disease, is one of the leading causes now of people needing liver transplants. Hepatitis B and C used to be the biggest players. Is there anything that can be done to prevent hepatitis B? There's immunization for hepatitis B. Can we immunize against hepatitis C? No, we can't. But for certain types of hepatitis C, there are treatments that will cure you of the hepatitis C. Now, that doesn't mean it won't come back if you're re-exposed, but the metabolic syndrome as a cause of chronic liver disease, at least in westernized countries, is becoming a major problem. The hyperglycemia and diabetes and the dyslipidemia, they're atherogenic. So there are multiple factors that are predisposing to atherosclerosis, and that can lead again to heart attack, stroke. So now on my little man here, I've added on this liver disease and abnormalities of blood glucose and blood lipids. So I want to say a little bit more about the hyperglycemia now. Diabetes is potentially got many, many severe complications. There are potentials for acute severe illness. They're uncommon in type 2, but they're unfortunately extremely common in type 1. So there's a condition that occurs in type 1 diabetes called diabetic ketoacidosis. That's rare in type 2. Hyperglycemic hyperosmolar state, which relates to coma, that's more common in type 2 than type 1. So these are some severe acute illnesses that can be life-threatening. When your blood glucose is very high, the white cells that protect you from infection don't work very well. And this can lead to pneumonia, urinary tract infection, and skin infections. Poor wound healing, another problem with diabetes. If we have a woman who is pregnant that has diabetes, there are multiple risks to both her and the fetus. And if mother's glucose is very high, that glucose will transfer into the fetus, and the fetus will get very big. And now you've got a very large infant. And what type of immediate problem might that pose at the time of delivery? It's difficult to deliver the big baby. The baby can be 10 pounds or more. So there are multiple pregnancy-related complications that are risks to mother and to the baby. Vascular disease, that's the other major area that is a consequence of type 2 diabetes and the metabolic syndrome as well. And we can talk about both micro and macrovascular complications. The microvascular complications are the small complications like retinopathy, nephropathy, or neuropathy. As far as the macrovascular complications leading to premature death, I've already mentioned those: the heart attack, the stroke, and the peripheral vascular disease. So these are serious ramifications of having diabetes. Now, can you do anything to control diabetes? You can limit your carbohydrate increase in their medications as well. So a little bit about the liver disease, and we're close within 5 minutes, Ken. Steatosis is when fat infiltrates the liver. And too much fat in any organ can put it into a pro-oxidant state. And that pro-oxidant state can lead to inflammation. And once you have inflammation that's chronic, that can damage the organ. Sometimes the liver becomes so damaged that it can no longer replenish itself, and it becomes hard and cirrhotic. So cirrhotic is a fibrotic liver. It's losing function. And ultimately, the liver may fail. And I've already talked about the need for, of people that are getting liver transplants, the number one cause now is fatty liver, going to liver failure. Also, with chronic inflammation, you can have liver cancer. So I think this is something that probably is not as well appreciated about the metabolic syndrome as the diabetes and the hypertension and the dyslipidemia is. It's estimated at least 25% of adults have the metabolic syndrome. Some estimates go up to 30 to 33%. At least 4% of children have the metabolic syndrome. So when I was practicing pediatric endocrine, when I was a fellow between 1981 and 1984, I only saw one boy with type 2 diabetes. And now, in a typical practice, probably 25% of all the kids that have diabetes have type 2 diabetes as children. The metabolic syndrome increases with age. It is more common in women than in men. And depending upon men or women, it is increased in frequency in various ethnicities. For example, if we look at women, Asian women have the metabolic syndrome more common than white women. more common than African American women. Okay, well, I've been, I've really laid out a whole bunch of black crepe, Let's talk about how it can be prevented and how it can be treated, because that empowers you to change the outcome of yourself as well as those you love. So exercise regularly, avoid obesity, or if you're overweight, try to achieve weight loss. Mediterranean diet has been shown to be very healthy, modest amount of carbohydrate, olive oil, fish, chicken, and fruit. I do not pretend to be a dietitian. So here's a picture up here on the right of lots of green and red. One way to assess risk for metabolic syndrome is to look at the body mass index. It is imperfect, but the body mass index is the weight in kilograms divided by height in meters squared. Another way to look at risk for metabolic syndrome is abdominal circumference. So if the waist circumference is increased in men by that amount or in women by that amount, that would increase the risk for the metabolic syndrome. It's considered that your BMI should be less than 25. And I just have disclosures of conflicts of interest to make here that my BMI, I did it a few days ago, is 25.1. So I'm on the cusp of overweight. Screen for prediabetes. So that's something that most physicians do. Actually, all physicians should do it, especially in our age group. That can be done with some simple blood tests, fasting plasma glucose, or a test called the hemoglobin A1C. Hemoglobin A1C is probably the most widely used test because you don't have to be fasting for that. Oh, also, for people that have diabetes, regularly testing of microalbumin, that's the amount of protein in the urine, is important because one of the major complications we saw of diabetes was nephropathy, kidney disease. Screen for hypertension, that's pretty easy. Probably all had our blood pressure taken many times. Dyslipidemia screening at least every 4 to 6 years. So that be done with a blood test. And these are the component tests within that lipid profile. It was interesting that there are some people that recommend, because anemia is common in people with the metabolic syndrome, that a complete blood count could be something that may be of value to look for anemia. And the value of screening for liver disease and high uric acid is unproven. So doing every test that's possible isn't necessarily good or informative. Likewise, measuring inflammation, CRP, or measuring your iron status through ferritin, or even measuring your insulin, because we've talked a zillion times about insulin, they're really not proven to be of value in clinical care of patients. Here's a lot of data about screening for diabetes, and I'm not going to go over this for the sake of time, but at our age, or at least my age, we're all screened for diabetes, and we should be screened on a regular basis. Treatment. Well, if possible, weight loss, exercise, healthy diet. Treat hypertension. Treat the dyslipidemia. Treat the diabetes. The American Heart Association has the following diagnosis for the metabolic syndrome. When 3 or more risk factors are present: high blood glucose, low levels of HDL, the good cholesterol, high levels of triglyceride, increased waist circumference or apple-shaped body, or high blood pressure, when any 3 or more of those factors are present, that the metabolic syndrome could be diagnosed. So in summary, obesity causes insulin resistance. Insulin resistance causes the metabolic syndrome. Metabolic syndrome is highly atherogenic. Despite all the things I've talked about, the thing we worry about most is the development of cardiovascular disease. Metabolic syndrome can be prevented, and it can be treated as well. So thank you for listening, and now if you have any questions, I'd be happy to answer them. Yes. Great question. The question was the benefits of the weight loss drugs, which are GLP-1 agonists, and people having tremendous weight loss, and diabetes can go away. The blood pressure can be reduced. The lipids can be reduced as well. So it has a lot of benefits. But I think we will find out about their long-term safety. I mean, we believe they're safe, but I'm not sure that we would put GLP-1 agonists in the drinking water yet. But we really had no tool before that that was successful in weight loss. I mean, if you go back to the 90s, do you remember fen-phen? It was a combination of two catecholamine drugs. And, if you look at people that use certainly illegal catecholamines like methamphetamine, people have tremendous weight loss. Well, they also die of all kinds of other problems. At the time that fen-phen was used, the major problem with that drug was valve disease. They actually got heart disease from it.
Sir, would you go over the benefits and disadvantages and advantages of apple, pear, and banana?
Well, I don't think there's a banana in the story, but the concept is that if most of your weight is here in mid area, those tissues are all going to drain through the liver. So you're going to have more delivery of fat directly to the liver, and the liver then becomes steatotic. Other organs become fat induced as well. On the other hand, if you have more fat in the buttocks, in the lower half of the body, that's not directly delivered to the liver. So some of it really is thought to be anatomy. Also, fat is not, when we think about fat, we usually think about fat as being the same throughout our whole body. But probably fat is not identical in various parts of our body. We know we have brown fat and we have white fat. And brown fat has very different metabolic activities than white fat. We also used to think that fat itself, other than being a storage form for carbon, if you take too much carbohydrate in your diet, too much fat, even too much protein, we can save that carbon as fat. And that is added to our adipose stores. But fat itself is actually hormonally active. It produces both local and systemic messengers that alter metabolism. So I think part of it has to be that fat is not homogeneous in the body, and where the fat is located seems to have an effect.
Just checking. Another risk factor for diabetes still continues to be genetics, correct? If there's diabetes in your family, you're at greater risk?
Well, certainly, okay, the question deals with about genetics and diabetes. If you have a twin, your risk of developing type 2 diabetes is probably 80 to 100%. So it is strongly familial, but it is so much more strongly related to obesity. If you look prior to, and if my spouse were here, Dr. Hart, she'd get off on high fructose corn syrup. If you look prior to the 80s, when high fructose corn syrup started getting put in everything, there wasn't as huge a problem with obesity as there is. I mean, do you ever go back and look at old movies like Casablanca or The Third Man? Well, maybe Orson Welles wasn't so thin, but you go back to the 30s, 40s, and 50s, and obesity was very, very rare. And so food is relatively inexpensive. Still, it's expensive compared to what it was a few years ago. But if we look at it from the viewpoint of other expenses, we're blessed that most people can afford, not everybody, but most people can afford food. So is it genetic? If you can choose your parents, I wouldn't choose parents to have had diabetes. If you look at type 1 diabetes, which is more of a childhood onset, only 15% of people with childhood diabetes have a first-degree relative. That would be a parent, a sibling, or an offspring that has it. So certainly genetics has a major impact on it. But there's been such a rapid change in both the frequency of obesity and type 2 diabetes, you can't account that for changes in genetics. And the last thing I'd say, because I know Dr. Cholera has a question, the last thing I'd say is evolutionarily, we never evolved an environment where calories were as abundant and cheap as they have been since the Industrial Revolution, and especially in the last 40, 50 years. What was life expectancy prior to the Industrial Revolution, prior to the, I guess, the 19th century? 40 years, yeah. And if you think about evolution, once you've reproduced, anything that is counter to your ability to reproduce, it doesn't matter. I mean, once you hit 40, you'd already reproduced. So the diseases of aging, there was nothing that was a negative against them, selecting against them. If it impairs your reproduction, it's going to be selected against. If it doesn't impair your reproduction, there's no selection against it.
Thank you, Bill. That was a great overview. I want to know the current thinking of the relationship between A1C and glucose. I was told that in some ethnic groups, you don't have that good a relationship to be diagnostic.
Okay. I think it's tight. And first of all, A1C is used as an estimate of average glucose. And we use it as a diagnostic tool for making the diagnosis of diabetes. We also use it as a measure of glucose over the last 2 to 3 months. So if you have diabetes, your doctor will do an A1C at least every 6 months. And if she or he is trying to, improve your control, they may be doing it every 2 to 3 months. I think the controversy is the cut point that we use universal in different ethnicities. And I believe in South Asians, a lower A1C can still be a risk factor compared for an A1C that we've defined in whites, for example.
That makes sense.
And if you look at, even in people that don't have the diagnosis of diabetes, and you look at different population groups, the average A1C is lower in whites than it is in Hispanics, than it is in African Americans. So I think we have to always think about, do the cut points that we're using apply to all the different people?
Yeah. Okay. Thank you.
So maybe we can take a question from the Zoom audience.
Jane wants to know, you mentioned a list where we have 3 of them that indicates metabolic syndrome. Can you say that list again?
Okay, I can remember. Well, first of all, I'll say that different professional organizations have different definitions. So the typical factors that are involved is, do you have type 2 diabetes or not? Are your triglycerides high or not? Is your HDL low or not? Do you have hypertension? And do you have some measure of adiposity? It might be your BMI, it might be your belt circumference.
Thank you for your excellent presentation. And yes, your offer to do another on the thyroid would be well received.
Thank you.
Okay, well, if there are no other questions, I just want to thank my friend and colleague for many years, Bill Winter, for a fantastic presentation. And you can see why he can take a complex set of data and information and distill it down so we all can understand it. And
We'll see what the test scores show. Did you all get the paper? Thank you.
thanks.
I just wanted to say that next week, the speaker